Hello and welcome everyone to this AGFA HealthCare RSNA webinar, where we will be talking about the future of imaging by 2030 and how enterprise imaging is going to shape how the radiology or the medical imaging ecosystem is going to develop. It is an absolute pleasure to have in the discussion today Dr. Kal Clark, who's the Associate Professor, Clinical Vice Chair of Informatics at UT Health San Antonio. He's also the founder and CEO at Zoron Labs. And also joining us from the UK is Dr. Sanjoy Nagaraja. He is the consultant interventional and diagnostic neuroradiologist at Sheffield Teaching Hospitals at NHS Trust in the UK. I'm your host today and the moderator. My name is Anjum Ahmed. I'm the Chief Medical Officer at AGFA HealthCare. Before we begin, I wanted to highlight here some of the key areas that are going to be the focus of our conversation today. What we are hearing from the industry, what are we hearing from our thought leaders in regards to their imaging challenges. We will also be taking your questions and answers towards the end. And please also participate in the session by sharing your questions in advance and also towards the end. Now, innovation at AGFA HealthCare. AGFA HealthCare, as you know, has been in the industry for over years, and we are part of the AGFA Gayward group that has over hundreds of years of history in terms of innovation. Our journey started within the radiology or the imaging IT landscape in the 90s, where we were honored to be the first PACS provider to many of our customers. As we progressed through the years, we were fortunate because a lot of thought-leading customers embarked upon this journey of transformation with enterprise imaging with AGFA. Their feedback, the way they challenged us, also helped us shape how we will evolve with our platform. And through the last few years, we have been nominated and received several awards as well in recognition of not only our clinical workflows and use cases that we have implemented, but also very high capabilities in terms of cybersecurity and some of the other use cases as well. So more recently, we have received triple class awards as well in this category. So that's something that also helps us even improve even further because our customers then obviously demand more from us. I wanted to first take a step back and think about what are the clinicians or diagnosticians thinking about when they are using these advanced systems. I'll open up and Sanjoy, Dr. Sanjoy and I recently had a good conversation and a small workshop we did at the Sheffield Teaching Institute where these workflow challenges were discussed. So I'll look at your opinion and not just this case overload piece and overall in terms of what you see in terms of radiology challenges.
Thanks, Anjum. Appreciate, first of all, the invite to be a part of this RSNA webinar, and it's great to be a part of this process. I think there are certain things that are unique to our environment within the United Kingdom, which is that we have a significant issue with regards to burnout. There is a huge amount of expectation in radiology with regards to the kind of studies that are being done, the more complex studies that are being demanded by systems and everything else that goes with it. It's a small anecdote that I usually say with most of my sort of, my passionate sort of defense of radiology as a subspecialty is that I know that in the UK, at least I can speak for the UK confidently, is that 97% of patient pathways go through radiology at some point or the other. So if you think of any patient that comes in either from an ED setting or from an outpatient setting or from a primary care setting, they all require imaging. Imaging is virtually impossible to replace within our current systems. We have evolved significantly from being the first plain film taken in the 18th century to where we are today, where there are so many complex imagings within so many multiple subspecialties, which is impossible to kind of put into a single, umbrella of investigations and say that's all we do. There are hundreds and hundreds of examinations that have evolved over the course of the last 30, 40, 50 years, which have made imaging very, very complex, which means that the pressure on the individuals who are delivering the service is real, because it is not the same that it used to be 30 years ago. Today, it's a different environment. There's not only the expectation to be open with some basic investigations like x-rays and fluoroscopies and the things that we used to do, but now we're going to very complex studies like dynamic CTs, multivoxel CTs, photon counting CTs. There are so many advances that have come through, which means that me as a neuroradiologist, I'm virtually oblivious to what something like what Kal would do in the US, where he's got a more general opinion of what things happen. I would be completely oblivious to that. 30 years ago, that would not be the case. So we're becoming more and more subspecialists, which then puts a lot of pressure on the system. And if you look at the patient journey that most patients go through, there are three phases, as you know. There is the journey from before the acquisition of the study, there is the acquisition of the study itself, and then there's the post-acquisition. So the challenge for any environment, whether it's AGFA, whether it's any other system, is how do you make that seamless? And that's the challenge that we face. The burnout is real. The work hours that people put in is real. The difficulty that we find in getting the right number of people to report these studies are real. The impact on the system is real. And the problem is, if you do not have the grease, which is radiology, the car isn't going to run. That's the reality of it. You do need the grease to help the moving parts move. And without radiology, all the systems come to a standstill. And that's the reality of what we're faced with today when we're talking about technologies.
I think that's a great point about the overall imaging complexity. I think the way to add on to that, radiology is, and I like talking about the systemic factors and then the human element. And maybe I can do the systemic factors first. The first one is that at least in the U.S., we're not paid for additional complexity in a medical exam, which is pretty unique amongst other medical specialties. If someone goes into a primary care office visit and they have a ton of medical conditions, then you can bill at a higher level of complexity. There's more factors that go into that. And so but in imaging, I get a normal chest x-ray or I get a chest x-ray that has a ton of findings. I'm paid the same. So there's, as the medical complexity goes up, the payment rates stay the same. Okay. Now we have the radiologist shortage. So there's no money to pay for, there's no increased money to pay for it. We have to do the same with the same amount of money. And then as the burnout starts to load up, as you correctly identified, and it's happening over here as well, there becomes more stringent requirements of, oh, like I'm not going to work on the weekend, or I'm going to do one shift, or I need to work X number of shifts. I'm not going to do any more. And so then we try to balance that by basically overloading certain types of shifts. So at our institution, some of our neuro shifts are insanely high, just because it's like, hey, like we can't find people to work to really, deal with that level of workload. And so the radiologists have kind of said like, okay, we're just going to work really hard for this one shift, but then they just can get annihilated on that one shift. And so they were trying to do it for recruitment reasons, or were trying to do it for lifestyle reasons, but it was kind of like a false choice, because they're just going to burn themselves out, because you can't read this, and then it's just like, oh my gosh, every work session you walk into, it's like, oh my gosh, am I just gonna, like, is this gonna be insane? Like, am I not gonna be able to deal with this? Like, how many mistakes am I going to make? And so it's just a vicious cycle. Okay, so that's on the radiologist side. Then we get to the ordering provider side. So I think we're always having to think about this from the producer and then the ordering user. From the ordering user, you have these large electronic healthcare provider, record provider companies, and they have become expert at how can we eliminate all friction to get from I want an imaging study to ordering that imaging study. So the upstream pipeline is just becoming very, very smooth. So you talk about like greasing the wheels. That wheel is heavily greased, I think, because it's click, 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 and now you can order your abdominal CT for whatever you want. And just like anecdotally, we can start to think about like what happens when these studies get delayed and these higher complexity studies, get ordered more and more and more. these ordering users now become like anecdotally, what's happened is that the ordering users have figured out that radiologists read maybe complex imaging exams before chest X-rays. And so what we've seen anecdotally, we haven't published anything on this, but we've seen ordering users say like, oh, well, I want answers now because the patient in front of me is demanding answers. So I'm going to order a chest CT instead of a chest X-ray because I know the chest CT is going to get dictated first. And so now we've kind of created our own demand for higher complexity exams just because of this weird quirk. So it is a very difficult problem to solve. And I think as long as we frame it as, you know, like, what is the ordering user experience? They're getting pressure on their side with increasing patient volumes, and for better or worse, like radiology has a very good test that can guide a lot of patient management. So they're gonna keep coming back to us for these sorts of solutions. So yeah, we just have to think smart about it. But yeah, I think this is on the right track.
Absolutely, which then brings the context of, you know, the rightly as you structured it, right? There are three phases of imaging acquisition. There is the acquisition phase, and there is post-acquisition. I think what we have seen is most of the automation that has been done in the system has been at the post-acquisition level. There has been some automation at the modality level, at the point of image acquisition, with protocoling on the modality level. But I think there is still a lot of room in terms of how automation can be brought into the other cycle of the image workflows. And that's where, when I think about how we implemented some of these rules-based automation technologies or intelligence into the core platform, and I spoke about it in the beginning, there are specific areas that we wanted to make sure that image distribution and image visualization becomes seamlessly accessible with true mobility. So you've been using enterprise imaging since few years, and as I mentioned earlier, Sanjoy, you and I had sat down together earlier this summer to think about some of those specific areas where you think visualization or automation, or for example, you prepare MDTs, how this may have helped you actually save a lot of time. So your thought on this particular aspect?
Yeah, thanks, Anjum. I think we are a unique system within the United Kingdom with regards to how radiologists interact in proper clinical care within the system. So we have a very robust system called MDTs, where every single pathology is virtually rubber stamped before you can get the go ahead for any kind of surgical procedure, and it's usually clinically led with radiology and pathology support. So it's a kind of a massive meeting that we do. And having enterprise imaging has made a massive difference in the way we look at these studies now. Previously, it used to be a manual task of trying to get the studies grouped up together, try and see if you can get the right imaging at the right time, make sure that they're all available for the radiologist to see. Now, with the new EI system, it makes it very, very easy to set these work lists up much ahead of, give it to an admin person who's running the MDT service, who can preload all the studies. And we've also now got the regional viewer as well, which makes our life very easy. We can now see scans from neighboring trusts and organizations, which then makes our life a lot more easy when it comes to decision making. From a challenge perspective, I think, it's a philosophical thought process, and it may not be very appropriate for me to say it, but I think the biggest problem radiology has is its own success, if I want to put it that way. We are now more certain of the things that we see, and we are able to pick up the disconnect between the clinical presentation and the pathology that we see. So you may have somebody who looks plumb normal and has a scan for some reason and is riddled with metastases. And you have the same opposite, where a patient has come in with the most aggravated presentation of pain, discomfort, and the scans are completely normal. So we have this disconnect now between what is deemed clinically urgent and what we actually see on the studies. And the challenge that radiology faces is, because of the extreme expansion in the amount of studies that we're doing, it's virtually impossible to police every study from a radiologist perspective. So you do need another system which can help you prioritize your studies. So, in the UK, we do a lot of screening programs. I don't know how well it's well known across the world. We do what are called as lung health checks, where we actually look at symptomatic patients within a population and give them CT scans of the chest to pick up tumors early. We have had some success with that, where we've picked up some tumors very early and they've been operated on with very good success. Pretty much like the mammography screening program that happens in the UK. So this is the challenge for radiology. The volume is going to increase. That's the reality of the world that we live in today, because of the advances imaging has made, and especially since the 80s and the 90s, clinical examination is no longer as valid as it used to be. It's more imaging led now. You're seeing things where people are doing clinical examinations. It's not that it's not important. I still think it's important, but there is a huge discrepancy in what we're actually picking up from what they actually see from a clinical setting. So radiologists are now become virtually impossible to replace in many ways, because without us, you're not going to get a diagnosis, and then you need a pathologist to confirm it. So the reality is, without the ancillary services, most clinicians are basically trying to fight or trying to box with their arms back, held back and tied up. So the reality is that's where imaging is, and the challenge that AGFA and all the other systems out there are going to face is, how do you sift through all the stuff that is coming through and pick up the ones that are important from a radiologist perspective to say, Kal, do you want to have a look at this scan first? Because there's something there that I think is abnormal. Like how you had your residents and your resident doctors and your senior house officers and your registrars look at scans, like, for example, through the night. And then in the morning, you sit with them and say, you go through all these and say, I agree with this, I don't agree with this. You essentially need a triage system to be created within radiology, which can be AI-led, can be whichever way you choose to do it. We have things like the red dot system in the UK, where a radiographer or a technician has picked up something on the scan, puts a dot on the scan and says, doctor, can you see this in the morning, and confirm whether it's right or wrong. So this is how technologies have been evolving with time. And the challenge that AGFA and all the big players in the field face is, can we dissociate this complete dependence on clinical priority? Can we make this different? That's the challenge that we face. Not only, so the pre-acquisition phase, obviously, if you're symptomatic, you go to a doctor. You're not going to screen every single person in the population for an abnormality. That's not going to happen. But even when you find things which are abnormal on a scan, which may not be expected, what do you do next? Those are the challenges that radiology faces. And how do you make the system seamless with regards to getting the information out there? Can this be automated? Currently, the pressure falls on the radiologist to communicate these findings, whether it's through the report, whether it's through an alert system, whether it's through a phone call that is needed. You are being pushed to the absolute extremes of work pressure, because say on a list, Kal is reporting 100 CTs. Now, if there is a 15% pickup rate, which is significantly high, that's 15 patients that he's got to spend time in contacting somebody, ensuring that that result is acted upon, and then he gets the satisfaction that he's done the job, or else it's not done. Medical legally, you still have the responsibility to communicate. Now, these are things that puts a lot of pressure on radiology. How do you ease those burdens that come through? So these are the challenges I think we need to look about. I think the advances that we have made so far, from, if you look at the primitive PACS system that we had in the 90s to the EI system that I have today, it's heaven and earth, isn't it? I mean, there's a massive evolvement of how easy it is to access previous imaging. Everything comes up. The hanging protocols work beautifully. You have 3D reformatting. You've got vessel analysis. You've got, a hybrid sort of looking at images, merging them together. You've got all kinds of automation that you do. CT angiograms with 3D mapping. Everything is at a fingertip now. Previously, those used to go through another source. You had to sit and swap your screens, look at the other companies, reformatting technology, then try and make that, put it into the normal system. All that has been circumvented now. this has now become much easy. But the problem is, because it's become easy, there's a lot more to do.
Exactly. Yeah.
And
Yeah.
that's the challenge. And I think that's where we need to see how do we get to the next level.
Absolutely. Thank you. I want to move further, just in the interest of time, and because it also ties closely to the evolution of what we think of a modern enterprise imaging platform, in terms of how, as you mentioned, these pain points, right? How do we streamline access to all imaging data in one user interface? Because there is advanced visualization. We want to make sure the number of clicks are reduced, and some of our customers have been reporting that they've seen 50% improvement or a reduction in the case preparation time because of some of these rules-based automation and intelligence that we have built into the system.
Yeah, I think the work list automation is probably the closest thing we have to a free lunch in terms of value that you can get from an enterprise imaging system. Because I think it's been pointed out, I think a lot of the hang protocol, the display, the speed to be able to see the first image, the scrolling speed, like these technical challenges have been largely figured out. Being able to display it to the user, so they don't have to come down to their reading room, that it's like in their hands. I think those issues have been solved, and that's kind of like the status quo, or kind of like the standard of PACS care for this industry. When we get to the subspecialty workflows, things get really interesting, because just to give you an example, AI triage systems have become we're one of the leaders for the industry of, okay, we're going to prioritize the work list from a clinical standpoint. Okay, that makes sense. So I'm going to give you an example of like where that may not make great sense. So for a stroke triage system for patient coming in with a stroke code, we kind of looked at those sorts of solutions, and it was like, oh, like, hey, this would be a really good application of AI. Let's identify when there's a stroke and a patient coming in with a stroke code, because we're not always aware. The issue is that we would be detected to that stroke, and we would call the clinicians like, oh my gosh, like there's a stroke on this patient, and we'd get the neuro specialist, the stroke code team on the phone, and it'd be like, yeah, we already know, thanks. So it's an example of where there's a clinical environment that's happening that from a radiology perspective we should be aware of. That's like, hey, like there's a specialist clinical workflow for a patient coming in with stroke, so maybe the stroke triage AI solutions aren't necessarily the first thing to go for, and maybe there's other optimizations. To give you another example, looking at like fracture detection algorithms for orthopedics, we were going to implement that solution, and it was like, oh, the faster we can detect this fracture, maybe we can like get this process moving a little bit faster. And the issue is that when we brought that to our ER colleagues, they were like, oh, well, like these patients that have fractures, they're usually not seen, for 2 or 3 hours, because it's like, oh, this is just a fracture workup. This isn't a chest pain or like an emergent. So usually they're sitting. So if you gave us the report in 30 minutes instead of 1 hour, it's not that big of a deal. So these are like, there's an entire world that we're not really privy to in the radiologist reading room of these kind of like the clinical workflow. And so what we focused on with our AGFA solution is really trying to get into the heads of the ordering user and saying, when do they really need this study? And why do they need it? And usually it's because, oh, the patient's getting discharged, the patient's coming in for an appointment, the patient is complaining, we need a bed, like this patient is occupying an ER bed, and we need to move them through and get them admitted, and this is like for workup. And so those things like are not visible to us as radiologists and as radiology providers. And what happens is that we show up at these executive board meetings with complaints from the users, and it's like, hey, dumb radiologist, why aren't you dictating my patient? Like this patient complained because you guys took forever. Like, why'd you do that? And I'm like, well, what are you talking about? Like, well, we're ordering it based off of complexity, or we're ordering it based off of stat, non-stat. And it's like, no, this is not you. Like, you guys are just totally oblivious to the realities of running a healthcare system. Why? Like, you need to do it better. And so I think as we get more towards being intelligent about those patient clinical workflow factors, that is what we need. The subspecialty work list is now, oh, this patient is being seen same day or being seen next day. Let's flip it. That's like, once we get to that point, then we can start doing more with less, because we've kind of lived in a blissful ignorance, I think, for a period of time, because we had maybe like a little bit of extra radiologist capacity. So it was all about like, let's just clear the list. Like, we clear the list, no problem, because it's all done. But now stuff is staying on the list for a prolonged period of time, and these complaints are going to get built up. So now we need a subspecialty radiologist triage system to triage these studies that aren't going to get read, because this is no longer the case. Like, the lists aren't getting read anymore. It's like, oh, how many days behind are you? How many weeks behind are you? How many months behind are you? Now we need these sorts of systems, where before it didn't really matter.
Absolutely. This is a very good example because, coming from neuro background, right, Dr. Sanjoy, you also were looking at how your subspecialty cases are pre-populated and they're pre-filled. So you're actually not missing anything of the cases, right?
Absolutely. I think I completely agree with what Cal says.
Yeah.
The challenge is to sieve through all the stuff that's coming through a radiology system and ensure that it gets the right person at the right time, so that the report can be efficient and of use. Because as Cal said, if the clinician has already made the decision to do something and we're getting excited about a result which has no value, uh, it's not what we're supposed to do, isn't it? It's supposed to be the other way around.
Yeah.
We need to be informing the clinicians that there's a problem that they need to act on. I mean, at the end of the day, we must understand that there's a patient at the start of this journey that needs care. So how do we make these systems efficient so that the care that we give to our patients is appropriate? That's what we're trying to get to. It's not about how how fancy the system looks. The system may look fancy, but it still needs to address the care that we need to give to our patients, which is the most important thing. And getting that kind of sieve to get the right scan to the right person at the right time to get that efficient report is the challenge that we face. That's a real true challenge.
Agreed, absolutely. Which brings me to say something that I'd like to say is that, when I think about the future of radiology or medical imaging, it will not be in the pixels that we read. It will be more about the impact that we want to achieve together. And that's where we at AGFA Healthcare are looking at this as a strategic opportunity in terms of getting this rich feedback that, from your perspective and your experience, is where do we go from here? Because there are emerging innovations. There is a lot of conversation about AI. AI alone can be a demanding conversation. Before I move to the next slide, which is about the future of autonomous AI in radiology, I wanted to get your perspectives about your experiences in the use of AI in your clinical practice. What message or what advice would you give to enterprise imaging solution providers like AGFA in terms of what we need to take into consideration? I'll start with Kal, with you first.
I think one thing to keep in mind, I'm really interested in quality control. As Zoran Labs, that's what we focus on. But from like a radiologist perspective, quality control is just going to become more and more of an issue. I mean, if I was a healthcare executive, leading a health system at this point, I'd be scared to death of, just radiology, because now we have multiple sites that are reading for us because we're not able to handle the workload with our own practice. So there's like multiple practices, multiple radiologists. The churn of radiologists and practices is just becoming insane as you're trying to find, you're trying to plug the leaks. And so I think quality control, at least if you have a unified AI system, those AI systems can help to ensure it's like, okay, even if I don't have great control over my personnel and my credentialing and getting onboarding for hospital systems, at least I can have AI kind of there to backstop some of the quality concerns, or at least I'll know what's going on. Because at the end of the day, it's going to be like my name on the hospital's board. It's not going to be the radiologist contractor practice that's a temporary that's going to fill in on the weekends. It's like that person's not on the hook. So I think that's a big plus for AI. And then I think the experience in AI has been this kind of using AI to help with speeding up acquisition for MRI sequences, that is very interesting, so that we can reduce radiation dose and do more MRIs. There's a lot of time where it's like, hey, an MRI would be great here, but we see just like CT, 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 just because it's an easily acquirable scan, and we know exactly how long it will take. So I think that's been, I think this kind of like acquisition AI and then the actual reading AI. My personal opinion has been, I'm not. We use some different triage systems for our practice, but my own kind of prediction and my own kind of pulse on the AI technology is that the report generation AI is really where we start to see a lot of reducing workload for radiologists. Right now, I kind of struggle. It's nice to have to know like, hey, look at this one, but it's the backseat driver problem, where it's like every scan now comes with a second opinion that now I have to resolve the pixels on the screen and then the boxes on the screen. And so now it's not just the pixels, it's like, no, oh, hey, like you have two tasks instead of one task. So it decreases error. It probably increases, maybe decreases. And I guess like, there's a lot of studies that will say like, oh, it improves time. But every radiologist is a little bit different. There's a human factor. There are perfectionists, and there are the ones that are like, hey, this is close enough. I'm pretty sure, like my confidence is X. And what we've seen internally with our own data is that the ability of a radiologist to work with an assistant, the efficiencies are just all over the place. And so if you find a cohort of AI friendly, AI cooperative radiologists, then your performance is going to be good. But you may have AI deleterious collaborations, and then your performance is going to be worse. So this is not the box AI, the triage AI systems, I think, are not entirely solved as a like, this is definitely the answer. But yeah, you just have to, this is why data becomes very important, is you have to know, okay, like which one should I deploy? Which one's better? Where's the false positives? Where are the true positives? What's that look like? How is this actually interacting with my system? And and I think we're going to talk about later. It's like, how do I know it worked, or how do I know I need to uninstall it?
Absolutely agreed. And that's where, Sanjoy, you had a conversation about the algorithms, and then there are the marketplaces, right? And the integration challenge, right? And the expectation to have this in your ecosystem as well within your enterprise imaging environment. Today, I don't know why, for certain reason, I felt, it's my personal opinion, that integration is usually considered as an afterthought. That first, the feature functionality of AI is pitched, and then if the feature functionality meets certain clinical requirements, then the discussion around, oh, okay, let's find out how do we integrate this now into our PACS. Your experiences with the AI and integrations.
So I've been involved with AI close to, I'd say about 6 or 7, 8 years now. And we were one of the first ones to get in the stroke sort of call AI algorithm, which we were using because we couldn't get access to imaging from our neighboring trusts. So even though it wasn't helping with the diagnosis, it was definitely helping us to view images to make decision on patients. So it essentially became a sort of a viewer platform rather than a diagnostic aid. So it didn't actually serve the purpose of detecting strokes. It served the purpose of us being able to see the images quickly on on a platform other than a PACS screen, essentially an iPad and a phone and everything else, which make life a bit easier. My only skepticism that I've had, and I've told you this in our face-to-face conversations as well, Anjum, is I don't think it's been tested well enough. That's my true concern, that there hasn't been any independent verification of what these things claim to do and what they actually perform on the system. In Sheffield, we have been quite forthright with regards to how we use AI. So we have had some very robust research guys who have been looking at the effectivity of AI within the system. We've done it for multi-vendor studies and chest x-rays. We're now doing one for CT heads to look at how good they are and how good the pickup rates are. And what we've seen is that there's so much of variation in how these algorithms perform on the same data set, it's quite concerning. And from my perspective, if I was a patient and I knew that there are 7 algorithms and they're all performing differently, I'd be very concerned to say, hang on a minute, this is supposed to be the panacea of radiology in the next 2 decades. Where are we? And I personally think there is a role for AI, and I think it's real. But I think as we look at platforms that integrate AI, there needs to be some true independent verification and understanding of what these can actually give us, and make sure that that is clearly spelled out to the people who are using it, if that makes sense. Because what you don't want is a system that says it's going to do this, and then you put it on and you find out that it's actually not doing what it said it's supposed to do. And we've always seen that there's a tendency to overcall, which is fine, because if you're looking at it from a purely prioritization perspective, a degree of overcall is fine. So I don't mind a few false positives. What I don't want is to miss that one pathology that's going to potentially have a life-changing sort of consequence for a patient. So we as radiologists and as people engaged in this process need to be AI friendly. We need to look at it from the perspective of pushing it to its maximum and understanding what its true limits are, and ensure that we optimize it for use in each individual environment in the way that they see fit. And I think there is a value in the big platforms that do this to be very, very tied in to how we evaluate it, because the true test of what you're doing is in its evaluation and its independence. Now, you can't have somebody set their own questions and mark them and say that they're doing really well. That's essentially what's happening in the current system at this point in time. There needs to be true independent verification of the data, and then applying these algorithms in the way we see fit for the patients that it solves. Because what we found is we looked at a chest x-ray algorithm that was used in South Korea, and we put it onto our UK database, and the findings were completely out because it was a completely different subset of patients. Now, that when we reflected that to the company, they were absolutely amazing. They said, true, this is what's happening. We need to look at it in a slightly different way. So there are some challenges. I think it's amazing that we have something that's going to help the cause of radiology in the long run, but we are not there. We are miles away from that process, and we need to acknowledge that, and we need to be extremely careful and evaluate these very, very, very studiously, and get the evidence out there to say that it works, and then take it from there.
I absolutely agree with you, and I think that's why we are now seeing this particular emerging conversations with agentic AI, because radiologists are very good at picking up and detecting findings, right? I think where the radiology or diagnostic imaging can benefit from AI and automation is going to be some of these operational tasks, right? If these could be automated, because earlier with you and Cal, we were having this conversation that there is so much data that already exists within the PACS database or an enterprise imaging repository, right? How do we extract this information and get some actionable insights and certain tasks that could be automated? So there are two perspectives of what we hear about these agentic AI or AI agents, as we hear about them now, that may influence the clinical utility of these algorithms to, for example, smart study assignment, tracking follow-up recommendations, and balancing radiologist workload with some of those specific use cases. They could also monitor compliance with the guidelines, trigger alerts for overdue imaging, or support quality assurance, as you mentioned earlier, Cal. That's one perspective. The other one was the nature of multimodality orchestration by bringing some of these AI tools into clinical practice for improving efficiency, helping reduce diagnostic delays. Uh, there is another emerging aspect that's not mentioned here in this slide is patient-friendly reports, because uh, referring physicians and patients, they have to consume all this information. Today, they have to go through reading all these reports and trying to make some logical sense out of this terminology that's used in some of these reports. So I think overall, in the next couple of years, the way we see that some of these automated tools or AI agents will be incorporated into enterprise imaging platforms to help automate or to help orchestrate some of these specific areas. I wanted to make sure that we get the perspective of our audience as well and take the Q&A session. Thank you for now. It was interesting conversation, and I want to thank you, the audience, as well, because I have noticed there are some interesting comments that have been popping up. So they're not in the Q&A chat, but these are direct comments. So I'll try to bring all those together into this conversation. I think before we proceed, I wanted to reflect upon also, Dr. Clark, with you. You know, there is this whole conversation this year at RSNA is in imaging the individual, right? And when I think about this, and when I also think about, you know, as they say, a picture is worth 1,000 words, and I think a medical image is worth millions of pixels of clinical intelligence. However, all head CTs, for example, are not alike. And you know, what about the individual patient in this context? Like, is it important for an imaging ecosystem? What should be understood in terms of this perspective when we think about imaging the individual?
Yeah, thanks, Anjum. I think just kind of coalescing that entire prior discussion and in the context of this new, specific RSNA initiative, that we kind of have this. What you heard today was a little bit of the how individuals are present, not just the patients are not just the individuals. The health systems are their own individuals. Maybe they have different priorities or specific areas of excellence. So like in San Antonio, we're a liver transplant destination. And so we work very closely. So we need almost like custom solutions for dealing with that patient population, for prioritization and being able to display complex imaging. And then from the radiologist standpoint too, every radiologist needs to be presented data like they're their own individual. They need to have hanging protocols that are specific to them. We know that improves diagnostic accuracy. So from the patient that can't sit straight in the image, that has to be corrected, or that they have some kind of urgent condition that needs to be addressed, that sort of clinical information needs to be presented as the patient as an individual. The organization needs to have their specific individual needs addressed and put at the fingertips of the radiologist. And then the radiologists themselves need to be addressed. So it's like there's a cluster of individuals, and it's either A, you use technology to solve it, B, you hire an army of assistants to do it, or C, you just don't do it and you fail. That's the choice.
Thank you. Sanjoy, any comments you wanted to make here?
No, I think Kal is right. I think tailored imaging is the direction of travel. You've got to tailor it to the population that you're serving. There's no point in having tests that have no value. Tests need to have utilitarian value, not only from the perspective of decision-making, but also the ease of the discomfort of the patient. There's no point in having a test that has of no diagnostic value. Just because you can do a fancy CT doesn't mean you need to do it. You may still get away with an ultrasound of the abdomen if you want to get to an abscess quickly. You don't need to wait for a CT scan. So it's about understanding what the needs of the patient are. And, you'd start talking about specialties. You have Kal, who talks about liver transplants. We do things like bone marrow transplants for patients with multiple sclerosis here, which is a super specialist service. So you need dedicated catering imaging to those subset of patients, which is going to be repetitive. It can't be recreated everywhere because it's quite complex. The protocols are complex, and it's very difficult to take it from place to place. So tailoring imaging to an individual is 100% the right direction of travel.
Absolutely. Which then brings the other perspective, right? Because traditional PACS systems siloed, imaging service lines, but the consolidation with enterprise imaging, bringing not just the radiology and beyond radiology, the multi-ology context. And one question also that popped up in terms of this scenario is like bringing radiology and digital pathology in regards to this image service line concept. So how can it help with this scalability and computer vision AI application, all bringing this together? Any thoughts on those and that perspective as well?
This is a complicated question because I think you can make a technology infrastructure where we need better research on things like spatiomics and radiogenomics. So, for example, when we get consulted to do a liver biopsy, usually we have a lesion. The lesion is determined when we're determining the best place to biopsy it. It's like, okay, what's the safest place? Because it's like, that's all there is. Now with radiogenomics, spatiomics, which is saying that a liver tumor may actually be multiple different types of tumors in one, and the pattern, the actual treatments may need to be responsive, and it's called like tumor heterogeneity. So you may need to actually biopsy specific parts of the tumor. That's the idea of spatiomics. So a interventional radiologist would then need to have some sort of overlay of computer vision intelligence to say, red heat map here, you need to biopsy anterior part of it, posterior part of it. There's that. That's how it gets translated. That's how it's going to show up in the clinical care. We can kind of get into like the amount of like technical infrastructure that has to exist to like digitize the slides for AI tech to kind of operationalize. I think that's like more of a more complicated scenario. But yeah, so I think it's like aggregating all this information, displaying it to the person that's doing the biopsy, and kind of giving that intelligence to say like, hey, here we're going to help you differentiate tumor recurrence versus just scarring. This is something I hear over and over again, that I think the meshing of digital path genomics into this like radiogenomics milieu is going to show up, and enterprise imaging just needs to be aware of it, and being able to display it appropriately, make sense of it to the end user.
Thank you. Sanjoy, any thoughts you want to share?
Yeah, so I have a slightly different view on this because in our ecosystem, we are looking at ways to make things simpler. And the biggest complexity you have within medicine currently is the fact that there are so many complexities interwoven together that make access to stuff very, very difficult. Now, at the end of the day, call me basic, call me old-fashioned, it's just DICOM data. And it's just HL7 data. So all that we're trying to do is bring data systems together that seamlessly connect with EPR systems that then makes decision-making for doctors who are at the other end of the spectrum looking at results and everything else easier. Now, our whole job in life is to make things easier for people. That's what I think I took medicine for. Now, you can make it as complicated as you want it to be, but you can also simplify it as much as you want it to be. So I have a view that anything integrated should be integrated. And if that's pathology, that's cardiac work, that's dental work, that's everything that needs to be under the patient's folder, needs to be within the patient folder. And companies like AGFA should be looking at those kind of directions of travel to integrate things in such a way that it seamlessly connects to the EPR systems that then makes diagnosis and follow-up much, much easier.
I absolutely agree, which also kind of correlates with the other comment that I just saw in the chat in regards to the biggest area of improvement in radiology in the next 3 to 5 years. And the industry trends, the way we have been observing, like bringing all this context of AI, computer vision, ologies consolidated together. With all these computer visions, I think the future direction will be not just towards automation, but being more predictive as well, and not just predictive and prescriptive as well towards care delivery. So I think AI remains part of this conversation. And when I think about AI, before I move towards my specific question on AI, the direct ask in this chat here is, what do you think we could do to improve this radiology practice with enterprise imaging or these emerging technologies? And what innovative trends do you see in the next 3 to 5 years? Kal.
Yeah, I just put myself into the position of my daily workflow, and then I just, every minute, every second is just opportunity, and how do we allocate those resources, because that's like what it comes down to at the end of the day. And so like what are the speed limits? So it's like what is the minimum? We know from like visual science that a radiologist can basically interpret mentally a chest x-ray in about less than a second. So let's call that a second. But then it takes 2 to 3 minutes to actually complete the thing. So what's going on? There's the synthesis of all the clinical information to answer the question. There's the dictation. There's the second guessing, like making sure like, oh, okay, I'm going to look over this 2 or 3 times just to be double sure. There's the finding the needle in the haystack. So like all these, we have like a lot of bloat, and this is kind of a luxury that is not present in other clinical specialties. So like you take a primary care visit, the actual like diagnostic part of it, I think, is just a very small component. It's mainly coordination of care, talking to the patient, developing rapport, like that stuff you kind of, I think is helping a little bit with the ambient listening and those kind of transcription techs. But I think there's much greater capacity for AI tech. So yes, I think in the next 3 to 5 years, it's like looking at measuring those areas to say where are those minutes being spent that we can delete, and just as an organization saying, okay, here we have a fixed pool of dollars. Do we spend it on a tool to contact the provider automatically to kind of put those 2 people together, and what are the cost benefits? Do we have automatic impression generation? Do we have automatic report drafting? Do we have these triage systems? And we just, it's a measurement game of like, what's the actual implementation science? So I think my answer would be is we don't really know for sure. I have my own guesses, but this is like implementation science just needs to take the reins here, and we need to be able to measure each of these factors. But I think right now we're not so much on the. I think most of the gains are going to come from these sort of like writing the text, getting the information out of the record into our brains is where the next 3 to 5 years where we're going to see the gains. The detecting, like shuffling the work list, I think is not as big of a gain. It's going to be important, but I think it's going to come from these kind of like aggregators and write the text for me.
And I think there is something that we discussed earlier as well, like aggregation of the data, whether it is in the form of patient summaries or fetching, pre-fetching, for instance, the electronic medical record or electronic health record information in the context of the current study or exam that you're viewing. Sanjoy, how do you think about all this aggregation and kind of bringing together in the context of the evolution towards the next few years?
I live in a slightly advantageous world compared to the Americas, where I'm not that fussed about the money part of it, because I live in a social healthcare system which is slightly more fortuitous from my perspective. From where do I see imaging in the next 3 to 5 years? I think it's going to be evolution in a significant way, where the roles of radiologists is going to become more dynamic rather than more static that we were in the past, where all that we did was sit and report. I think interventional radiology is going to progress in a massive way, where people need to be getting their act together and becoming part of teams. And I think that's what it's going to evolve into. AI is going to become integral to some of the work that we do. And I think it's going to be in the pre-acquisition phase and the acquisition phase. And I think those are going to be some significant efficiency gains that we're going to get. I think automated reporting is going to come into the picture as well. True negatives, where you can exclude something through AI, may be something that's going to come in. So your expertise is going to become more and more valid, because you're only going to be asked with things to say about things that are actually wrong, rather than saying it's actually normal. So the game changer is going to be, we're going to become more valuable to clinicians, because AI will not have the capacity or the capability to call accurately. It'll significantly overcall, which means diagnosticians will still come to you and say, can you help me out here? Because AI is telling me it's all these things. Which of the things do you think it's possible? Because what I've seen from the algorithm so far is that it's got a 30% overcall rate approximately, which means that 3 out of 10 patients are going to get inaccurate diagnosis. So there's a lot of work to be done in conjunction with radiology to ensure that the quality of information that you're going to generate from these processes are going to be accurate and patient valid. And radiologists should be taking the step forward rather than backward to become more integrated with these systems and challenging these systems a lot more so that you can get the best results for the patients.
Absolutely. And I think my comment, based on what I'm hearing from you and also the industry trends, is radiology is destined to become, I would say, a consultative powerhouse of data intelligence, evidence-based data intelligence, because radiology has been at the forefront of this digital transformation. If you think about the number of regulatory cleared AI algorithms in medical imaging, 80% of those regulatory cleared algorithms are in radiology. And there has been a lot of learnings and takeaways as well as part of this experience. So my usual point here is that radiology will become that consultative powerhouse of evidence-based intelligence, and they will become those coaches and guides to the referring physician and the other ologists in terms of providing that, guidance towards patient care. These are my thoughts, and I would like to conclude this session in the next 2 minutes with your final comments, starting with Kal.
I think radiology probably has one of the biggest opportunities biggest opportunities to solve some of its own problems, because there is such a technical solution, and the pixels and the places where we work are so fungible and can be so virtualized, that I think I'm kind of envisioning that a lot of the burnout things, we have like a global workforce, and our ability to use technology to deploy that entire global workforce to solve our own problems, I think is going to be ultimately the answer. And it's going to take good tech and good implementation and good thought leaders to meaningfully and thoughtfully deploy it. But yeah, this is not like we have to build buildings to solve it. Like every other practice in medicine, we have this kind of like software as a service, radiology as a service possible future.
Thank you, Kal. Sanjoy?
And I think in the interest of time, I'm just going to make one statement. We may work in dark rooms, but the future is bright.
Excellent. Thank you so much. Thank you. Absolute pleasure having you both. And I want to thank not only you but also the audience who have stayed and also were providing some interesting chat commentary as well. So absolutely appreciate the time provided by the audience. I want to thank RSNA as well for helping host and conduct and moderate this session. So I hopefully we'll see some of you at RSNA this year.